Awesome. Thank you so much, Ethan. That was a wonderful presentation, as well as Arnold. These are great updates on both the imaging, physiology, as well as access. And maybe I'll kick it off with Dimitri. I know, Dimitri, you've done a lot of work with radial. Safari STEMI was negative in terms of benefit for radial or femoral. Does it change your approach, or you still think radial is the way to go?
Yeah, thanks, Manas. It's a great question. And first of all, I think Safari was a great trial. It's unfortunate it was prematurely stopped, but I think it gave us a lot of information to understand what is the contemporary STEMI vascular management looks like in experienced femoral hands versus radial hands. And so I think what's important is to understand that if you are a very experienced femoral operator and you do your access well with ultrasound, micropuncture, and other safety techniques, and you use GP2B3As liberally, bivalirudin perhaps frequently, and things like that, that you can achieve low bleeding rates comparable to the radial complication rates. And so I think, whether you want to do radial first, which is a very reasonable strategy, versus femoral for those who are experienced operators, I think those are both alternatives. There's no absolute necessity that you have to quickly jump to one or the other, but be experienced with one and very well, and practice that in your center so you can achieve the best outcomes for your patient.
So, and I think, Arnold, you've done a lot of work with Faust and Roust and ultrasound. It looks like the role is becoming more and more, although the study you showed was not really positive. Do you think everyone should use it? And I'm actually curious on the panel, who does routinely use ultrasound access for their access? Okay, so most people do. So Arnold, I know you're the expert on this. What are your thoughts? What is the current status? Anything we should know about?
Yeah, thanks. I think, I think there's a recent JACC article on use of ultrasound on TAVR, and they interestingly didn't show a benefit to ultrasound despite other trials suggesting that there was a benefit. They haven't randomized that, so I think the question is still out. However, it did really specify that if you're comfortable and have the advantage of CT imaging of the femoral artery, that you have the advantage of contralateral access, that ultrasound may not have as much benefit as we might have expected for a large bore access. On the other hand, those who were with ultrasound, you could potentially do you could obviate the need for some of those other techniques. So I think I think the message of the editorial for that trial was important, which is do what you're most experienced with, but be experienced with ultrasound so that you can utilize all the techniques to the optimal extent. So I don't think you absolutely have to use ultrasound for every patient, but I think there's definitely a benefit, especially in the femoral and probably in the large bore. Radial, I think you're really just going to help speed your access and not really reduce complications, because the complication rate in radial is so low. And so I think these messages were really already expressed in the Faust and Rouse trials, and I think the subsequent studies have basically confirmed them.
Awesome. Thank you very much, Arnold. And then Sripal, I know that now the FFR seems to be the FFRCT, or the angio FFR seems to be gaining ground. How do you think that impacts the ischemia findings? Is that now a better way to assess things in the cath lab?
Yes, I think we do need more data. I mean, in terms of non-invasive FFRs, and also, the QFR, which you're referring to. But I think it's promising. We need more data. And specifically, if you're looking at non-invasive with a CT and adding on FFR may be more additive, but definitely we need more data.